So good morning. Welcome to the next session. It's my pleasure to moderate this together with Flavio Ribicini. And we will talk about a very important issue, and that is the antithrombotic treatment now in the context of transcatheter aortic valve implantation. I think you all agree that transcatheter aortic valve implantation constitutes a paradigm shift in the way patients with severe aortic stenosis are treated. And I think there are some important analogies to percutaneous coronary intervention, and therefore it's very appropriate to discuss not only the technique, but probably during the peri-procedural, but more importantly, long-term period, the ancillary concomitant antithrombotic therapy. And in this context, it's my pleasure to introduce Paul Guedeney. I hope I pronounced it decently, who is a colleague of Jean-Philippe Collet, and he will introduce the topic of antithrombotic therapy in transcatheter aortic valve implantation. Please.
Good morning, everybody. It's my great pleasure to present to you this lecture on antithrombotic treatment in TAVR. I have no disclosure of interest. Now, to start with the beginning, I would like to say a few words about peri-procedural anticoagulation for TAVR procedures. Now, because of the elevated risk of thromboembolic events, anticoagulation is required during TAVR procedures, and in daily practice, it is unfractionated heparin that has been used as a standard procedural anticoagulation regimen for TAVR. Usually, anticoagulation is started after the insertion of the regular sheets and prior to the placement of the large sheets into the vessel, and is continued to maintain an activated clotting time, or ACT, about 300 seconds, that was based on a 2012 expert conference consensus that also recommended that the anticoagulation with UFH be antagonized at the end of the procedures using protamine sulfate. It has to be noted that practice and local protocol may vary according to the center that you would consider. And I would like to remind you the results of this interesting study that was published in the JACC Cardiovascular Intervention Journal in 2014. In this study, the author retrospectively compared two strategies for peri-procedural anticoagulation. On the one hand, you had a baseline ACT-guided UFH dosage, and the other hand, you had the body weight-based dosage of UFH. In both cases, anticoagulation was subsequently adapted to maintain an intraprocedural ACT between 200 and 300 seconds, and in both cases, the anticoagulation was antagonized at the end of the procedures. Now, what this study reported is that the strategy of baseline ACT-guided UFH dosage was associated with a significant protective impact with respect to major bleeding, with an adjusted ratio at 5.9% at 30 days, compared to the strategy of body-weighted-based strategy. And interestingly enough, the occurrence of access site bleeding that were not defined as a major or minor vascular complication were also significantly reduced with the strategy of baseline ACT-guided dosage of UFH, while there was a trend toward a lower incidence of non-procedural related bleeding as well in the ACT-guided group. Now, if we talk about peri-procedural anticoagulation in TAVR, we have to mention the BRAVO 3 trial. And the BRAVO 3 trial was the largest randomized controlled trial that compared direct thrombin inhibition with bivalirudin to the unfractionated heparin for peri-procedural anticoagulation in TAVR. This study randomized a total of 802 patients to undergo transfemoral TAVR, and this study did not demonstrate any significant differences between the two anticoagulation strategy with respect to the occurrence of major bleeding within 24 hours or with respect to the net adverse cardiovascular event at 30 days. And of importance, there was no difference between the two anticoagulation strategy with respect to the rate of stroke at 30 days. Now, considering these results and considering the lower cost of unfractionated heparin compared to the one of bivalirudin, also considering the fact that you can rapidly antagonize unfractionated heparin, which you cannot do with bivalirudin, it has been thus considered that heparin should remain the standard of care for peri-procedural anticoagulation for TAVR, although bivalirudin could be a viable option for patients that are unable to receive heparin treatment. And for instance, I'm thinking about patients with a history of heparin-induced thrombocytopenia. Now, if the choice of the agent for the periprocedural anticoagulation in TAVR does not impact the rate of stroke during the procedures, what can we do to reduce this event? The answer may lie in the use of periprocedural cerebral protection device. And in fact, periprocedural stroke in TAVR can be considered as a, apologize for that. Periprocedural stroke during TAVR is a stroke that occurs within 24 hours of the procedures, and most of these periprocedural stroke result from the embolization of tissue-derived debris. And these debris are mostly a consequence of the mechanical interaction between the device on the one hand and the calcified aortic valve on the other hand. And in fact, neuroimaging studies have shown that these debris are a very frequent complication of the TAVR procedures, as new cerebral emboli may be found in nearly 2/3 of the patients. And interestingly enough, this very high rate of silent neurological emboli does not often correlate with the rate of overt clinical events, which is more likely around 5%. Now, there are several types of periprocedural cerebral protection device that have been tested in dedicated studies. I would like to emphasize the results of the CLEAN TAVI trial, which evaluated the Claret Montage cerebral protection system in 100 patients with a systematic post-TAVR MRI evaluation. And what that study showed is that the cerebral protection device was associated with a significant reduction of both the number and the volume of new cerebral lesion within 2 days of the procedures. Interestingly enough, the beneficial effect of this protection device was not only seen in the potentially protected neurological area, it was also observed in the overall brain. And more recently, you have this study that was published in the European Heart Journal, which presents the patient-level analysis of the pooled data of the Sentinel USID trial, the CLEAN TAVI trial, and the Sentinel registry. The author used a propensity score matching to adjust for potential confounder and compare 533 patients undergoing TAVR with a neurologic protection device to 533 patients undergoing TAVR without such device. And the results are quite clear, with a 65% significant reduction of the rate of procedural stroke as defined by the VAR2 criteria within 72 hours. Now, before we talk about post-TAVR antithrombotic therapy, it is important that we remind ourselves of what we're trying to protect the patient from following TAVR. And that is mainly stroke, atrial fibrillation, while not increasing the risk of bleeding. Now, what is the prevalence of pre-existing atrial fibrillation in patients undergoing TAVR? If you look at these data, representing approximately 50,000 patients from 11 recent randomized controlled trial or large national TAVR registry that were published within the last 2 years, you will see that atrial fibrillation, pre-existing atrial fibrillation, is a very common condition that may concern up to a quarter of these patients. Consistently, you will see that the rates of stroke at 30 days and 1 year are significant, even in the setting of contemporary TAVR and with potentially lower risk patients, and is estimated to be around 3 and 5% at 30 days and 1 year, respectively. Therefore, there is definitely a need for an adequate antithrombotic treatment to protect this patient from this ischemic complication. However, you have to consider the timing of the occurrence of the events. And in fact, the occurrence of stroke following TAVI can be classified as an acute, if occurring within 24 hours of procedures, subacute if it occurs between 24 hours and 30 days, or late if it occurs after 30 days, up to 1 year or even later. It is essential to discriminate the various pathophysiological mechanisms of ischemic events, particularly stroke, according to the timing of occurrence compared to the procedure, to better assess the optimal antithrombotic therapy following TAVR. Now, although there is clearly a need for antithrombotic protection to prevent from this ischemic event to occur, we cannot forget that these patients are at a high risk of bleeding complication, particularly when we consider the most frail group of patients who usually present with the highest operative risk at baseline. And you can see from that graph that the rates of life-threatening or disabling bleeding following TAVR were almost always above 10% within 30 days of the procedures, and you can see that the rates keep increasing long after the procedure is done. This emphasizes that the risk of bleeding continues long after the procedure is completed. And in fact, if you look at the data from the Partner 1 trial and the Continued Access Registry, you can see that the late major bleeding event that were defined as a bleeding occurrence after 30 days of the procedures and within 1 year were reported in up to 6% of the patient and were strongly associated with late mortality with an adjusted hazard ratio of 3.8. This emphasized the need for caution in the choice of the antithrombotic treatment in this frail population, as we were all reminded with the recent results of the Galileo trial, which we will discuss later on in this presentation. So antithrombotic therapy following successful TAVR should prevent from the occurrence of ischemic events that are related to the comorbidities of the patients, but they should also protect the patients from the specific complication of the use of a bioprosthetic device. And what specific complication am I talking about? Obviously, subclinical leaflet thrombosis. Now, clinical and symptomatic bioprosthesis thrombosis remains, fortunately, a relatively uncommon event. However, subclinical leaflet thrombosis are much more frequent if you use imaging-based studies. How do we define subclinical leaflet thrombosis? The most frequently found diagnostic criteria is a hypoattenuated leaflet thickening or a reduced motion of the leaflets at computed tomography scan imaging. Another potential criteria is a hemodynamic deterioration, which would be defined as an increase of the mean transprostatic valve gradient, or the appearance or the worsening of an intraprostatic regurgitation, although these criteria may be less frequently found. Finally, all of these criteria should favorably respond to the initiation of anticoagulation therapy. Now, if you look at the data of the Resolved and Savory Imaging Observational Registry, you will see that a subclinical leaflet thrombosis of a bioprosthetic aortic valve was found in 12% of the population according to computed tomography imaging. And interestingly enough, the subclinical leaflet thrombosis was more frequent in patients undergoing TAVR, where it was at 30%, than in patients undergoing surgical aortic valve replacement, where it was about 4%. And in this study, the use of anticoagulation was associated with a significant reduction of the incidence of reduced leaflet motion compared to both non-oral anticoagulation or compared to dual antiplatelet therapy. And this beneficial effect of oral anticoagulation was seen with both vitamin K antagonist as well as non-vitamin K oral anticoagulation agent. On the other hand, the use of dual antiplatelet therapy was not associated with a significant reduction of the leaflet thrombosis compared to single antiplatelet therapy. And these findings are not limited to all the cases of TAVR and can be also found in more recent patients, which usually present a lower operative risk. That would be defined as a STS score below 3% within 30 days. And in this first prospective TAVR cohort, only including patients with a low operative risk, Waxman reported a 14.0% prevalence of hypoattenuated leaflet thickening and an 11.2% prevalence of at least moderately reduced leaflet motion, leading to a total of 7.4% prevalence of hypoattenuation affecting motion of the device. Now, what are the mechanisms involved in the occurrence of this bioprosthesis thrombosis in TAVR? Some of the mechanisms involved are directly linked to the type of the device used and the deployment condition. And in this sub-study of the Resolved Imaging Study, the author analyzed the anatomic and deployment geometries of the patient and correlate them to the incidence and the volume of the thrombosis. And what they found is that a leaflet thrombosis was less frequent among patients that had an underexpanded aortic recipient, but they did not find this association with other types of device, such as the core valve or the Evolute Air device. Consistently, they found that thrombus volume was actually reduced in case of supraannular localization for specific device, such as the core valve device or the Evolute Air, and once again, this association was not seen with other types of device, such as the SAPIEN 3 device. Overall, how can we interpret these results? Well, we can suppose that maybe the device geometry and deployment condition will impact the surrounding area and may create or worsen a stagnation zone that could favor the occurrence of thrombosis. Other determinants of valve thrombosis have been described, particularly when using echocardiographic-based criteria for valve dysfunction. And in this study from the National French Registry, which include 2,500 patients with at least 2 available echocardiographic evaluation, we found the presence of bioprosthetic valve dysfunction to be more frequent in case of increased body mass index, in case of prior TAVR, or in case of chronic kidney disease, or the use of smaller size device. To the contrary, a non-femoral access or the use of oral anticoagulation at discharge were protective from such events. Overall, there are several pathophysiological mechanisms that are involved in the bioprosthetic device thrombosis, and among these mechanisms, we can cite a systemic prothrombotic state that can be found in case of altered left ventricular ejection fraction or lower reduced cardiac output, that can also be found in case of suboptimal anticoagulation therapy or in case of concomitant atrial fibrillation. The thrombosis process may also be initiated by the exposure of tissue factor. Now, this tissue factor is contained in the thickened native valve leaflets and may be exposed by the endothelial disruption that occurs during the procedures. The tissue factor may also be activated by the altered flow or the low shear stress that can be created by the crushed native leaflet, as well as the underexpansion or malapposition of the device, which can lead to the creation of a neosinus. Overall, this local condition may lead to thrombosis around the valve of the sinuses, of the sinuses of Valsalva, and explain why valve-in-valve procedures, the use of balloon expandable valve, or the use of small device diameters has been identified as a risk factor for device thrombosis. Now, should the presence of a subclinical leaflet thrombosis be a source of worries? More precisely, is there an association between a computed tomography-defined leaflet thrombosis and cerebrovascular outcomes? Well, the answer seems to be yes, if you look at that meta-analysis of 6 observational studies, where the author found a prevalence of computed tomography-defined leaflet thrombosis at 11.6%. And they found the presence of such thrombosis to be a significant marker of the risk of transient ischemic attack with an odds ratio at 5.9, as well as the risk of stroke with an odds ratio at 2.6, and the risk of major adverse cerebrovascular and cardiovascular events with an odds ratio at 2.1. So how should we adapt our antithrombotic therapy to prevent this device thrombosis and its potential clinical implication? That would depend on the pathophysiological mechanism responsible for the initiation of the thrombosis of the bioprosthesis. And in this regard, there are 2 main hypotheses. The first hypothesis is the antiplatelet hypothesis, where you want to mediate the stent-mediated risk of platelet-related thrombosis and embolization, and for that you should use dual antiplatelet therapy. The second hypothesis is the antithrombotic hypothesis, where you aim at preventing the thrombin-induced thrombus formation, and for which you should use oral anticoagulation. What are the pending issues in the field of antithrombotic treatment following TAVR nowadays? Basically, the main question could be summarized as follows. Should we use anticoagulation or should we use antiplatelet therapy following TAVR? And if we should use antiplatelet therapy, should we use dual or single antiplatelet therapy? Or if we should use anticoagulation, should we use vitamin K antagonist or should we use NOAC? The current guidelines, which are mostly based on expert consensus, recommend that in patients without an indication for oral anticoagulation, a dual antiplatelet therapy be initially used and then switch to a single antiplatelet therapy. There are certain specificities with the European guideline that consider the use of a single antiplatelet therapy in case of high bleeding risk from the get-go, and the American guidelines consider the use of oral anticoagulation with vitamin K antagonist for a short initial period. And among patients with a chronic indication for oral anticoagulation, both the European and the American guidelines agrees on the use of vitamin K antagonist and oppose one another on the systematic association with antiplatelet therapy. Now, the ARTE trial was the largest randomized trial to compare dual to single antiplatelet therapy following TAVR in patients without an indication for chronic oral anticoagulation. And although this trial was prematurely interrupted for slow enrollment with the enrollment of 222 patients out of the 300 initially planned, it still reported a significant signal in favor of single antiplatelet therapy with a significant reduction of major or life-threatening bleedings within 3 months of TAVR. There was a trend toward the reduction of the composite endpoint of death, stroke, MI, or major or life-threatening bleedings that was also present in favor of single antiplatelet therapy compared to dual, and there was no alarming signal associated with the use of single antiplatelet therapy. And these results were further confirmed by the present analysis. In this analysis, the data from 3 randomized controlled trials comparing DAPT to SAPT were pooled and analyzed. In this study, all events were adjudicated according to the VARC2 criteria. And what the author reported is that at 30 days, dual antiplatelet therapy was associated with a higher risk of the combined endpoint of death, major or life-threatening bleeding, and major vascular complication, as well as the risk of major or life-threatening bleeding without any alarming signal with respect to ischemic events. Now, about the use of oral anticoagulants in TAVR. In this particular study, a total of 11,500 patients included in the France TAVR registry from 2013 to 2015 were evaluated for long-term determinants of all-cause death. Approximately 1/3 of these patients presenting with baseline atrial fibrillation, and approximately the same proportion were discharged on oral anticoagulation, mostly with vitamin K antagonists during that time period. Now, this study reported an increased mortality in patients discharged with oral anticoagulation, despite many adjustments on confounding factor, including atrial fibrillation. Now, obviously, this study is limited by its observational nature and the persistence of many confounding bias, but it nonetheless emphasized the need for a potential safer alternative for oral anticoagulation than vitamin K antagonist. And what about the added value of antiplatelet therapy to oral anticoagulation after TAVR? Well, this study represents a multi-center evaluation of 621 patients presenting with atrial fibrillation and undergoing TAVR. Post-TAVR prescription in this study was categorized as vitamin K antagonist only or multiple antithrombotic therapy in case of association with single or dual antiplatelet therapy. And with a median follow-up of 13 months, the author reports, they did not find any significant difference between the two groups with respect to major adverse cardiovascular events, death, or stroke. However, they reported a significant increase in the risk of major or life-threatening bleeding associated with the use of multiple antithrombotic strategy with an adjusted hazard ratio of 8.9. With respect to the use of NOAC in TAVR in patients with oral anticoagulation, we have only limited data. And I would like to bring your attention to this particular retrospective registry, which evaluated nearly 1,000 patients from 4 large European centers. And interestingly enough, and contrary to prior studies, observational studies that were smaller in size, the author reported NOAC to be associated in a significant manner with an increased risk of all-cause mortality, MI, or any cerebrovascular event compared to VKA. Obviously, this is an observational studies, and the result will need to be confirmed by the large ongoing randomized trial. Now, in this study, Chakravarty reported the outcomes of the patients according to the treatment at discharge in about 5,000 patients from the Partner 2 randomized trials and the non-randomized registry. You can see here the repartition of the antithrombotic treatment at discharge, with nearly half of the patients being discharged on dual antiplatelet therapy, 20% being discharged on single antiplatelet therapy, and 25% being discharged on oral anticoagulation with either single or dual antiplatelet therapy. And in this study, the author did not find anticoagulation following TAVR to be associated with any significant differences in terms of aortic valve gradient or valve area. Although fewer patients on anticoagulation presented with a rise in transprothetic mean gradient above 10 millimeters. With respect to the clinical outcome following TAVR, the authors did not find any independent association between oral anticoagulation at discharge and stroke or any other outcome for that matter, including death, rehospitalization, and aortic valve intervention. What about ongoing trials? Various strategies of antithrombotic therapy are being tested in large dedicated randomized controlled trial. Among patients without an indication for chronic oral anticoagulation, single antiplatelet therapy is being compared to dual antiplatelet therapy in the soon-to-be-published popular TAVI trial, while a strategy of systematic anticoagulation was evaluated in the recently published Galileo trial and is still being investigated in the ongoing Atlantis trial. Among patients with an indication of chronic oral anticoagulation, the non-vitamin K oral anticoagulation edoxaban is being compared to vitamin K antagonist in the Envisage TAVR AF trial, while apixaban is being compared to the standard of care, that is vitamin K antagonist, in the Atlantis trial. And finally, the popular TAVI is evaluating the added value of antiplatelet strategy to oral anticoagulation. A few words about the Galileo trial that was recently published in the New England Journal of Medicine. The Galileo trial was an open-label, international randomized controlled trial comparing a rivaroxaban-based antithrombotic strategy to a strategy of antiplatelet therapy only following successful TAVR. In the rivaroxaban therapeutic arm, patients were treated with 10 milligrams of rivaroxaban once a day in association with aspirin for the first 3 months following TAVR. Then aspirin was suspended and rivaroxaban was prolonged. In the control group, patients were treated with dual antiplatelet therapy with aspirin and clopidogrel for the first 3 months. Then clopidogrel was stopped and aspirin was prolonged. The primary efficacy endpoint was a composite of death, stroke, MI, and any thromboembolism or thrombosis. And the primary safety endpoint was the rate of life-threatening, disabling, or major bleeding according to the VAR2 criteria. Now, that trial was prematurely interrupted by the Data and Safety Monitoring Board after the randomization of 1,644 patients because of safety concern with the rivaroxaban arm. And in fact, if you look at the main results of the study, you can see that rivaroxaban was in fact associated with a significant increase of the primary efficacy endpoint, with an incidence rate at 9.8 per 100 patient year, compared to a 7.2 per 100 patient years in the antiplatelet-only groups. And there was also, and this is very important, an increase in the risk of all-cause death with rivaroxaban with an incidence of 5.8 compared to an incidence of 3.4 per 100 patient year with the antiplatelet-only strategy. Now, the Galileo trial also included a sub-study that was called the Galileo 40 trial, which included 231 patients that underwent evaluation by a 4-dimensional computed tomography at 3 months, which was the end of the dual antithrombotic treatment period in both groups. The primary endpoint was the percentage of patients with at least one prosthetic valve leaflet presenting with a motion reduction that has to be at least a grade 3 or higher, meaning that it has to involve at least 50% of the leaflet. And they found that the primary endpoint was present in only 2.1% in the patient randomized to rivaroxaban, while it was present in 10.9% in the patient randomized to the antiplatelet therapy. On the other hand, a thickening of the at least one leaflet was observed in 12.4% of the patients treated with rivaroxaban and was significantly more frequent in patients treated with antiplatelet, where it concerned about 32.4% of the patients. Now, the popular TAVI is a prospective, randomized, controlled, open-label, multi-center trial that is testing the hypothesis that monotherapy with either aspirin alone or oral anticoagulation alone is actually safer than the addition of clopidogrel for the first 3 months. The trial includes 2 groups. The group A is a natural follow-up of the ARTE trial and only includes patients without an indication for chronic oral anticoagulation. And in this group, patients are randomized in a 1:1 ratio to aspirin or aspirin plus clopidogrel. And the second group, the group B, patients with a chronic indication for oral anticoagulation are randomized to oral anticoagulation plus clopidogrel or oral anticoagulation alone. The primary outcome is freedom from non-procedures related bleeding in 1 year, and this outcome will be analyzed in a superiority fashion. The secondary net clinical benefit outcome is the freedom from the composite of cardiovascular death, not procedural related bleeding, MI, or stroke in 1 year. And this composite endpoint will be analyzed for non-inferiority. The Atlantis trial is a multi-center controlled trial that will randomize approximately 1,500 patients to a strategy of systematic APIC7 to the standard of care. There are several differences between the Atlantis trial and the Galileo trial that evaluated rivaroxaban. In the Atlantis trial, patients will be stratified on the pre-existing need for chronic oral anticoagulation. And in the experimental arm, patients will be treated with a 5 milligram twice-a-day dosage of APIC7, or a lower 2.5 milligram twice-a-day dose of APIC7 according to the drug level, but there won't be a systematic association with antiplatelet therapy, as it was the case in the Galileo trial. The primary endpoint will be quite similar to the Galileo trial and will be a composite of all-cause death, stroke, MI, and any venous or arterial thrombosis, as well as the life-threatening or major bleeding according to the VAR2 criteria. Finally, we have the Envisage TAVI-AF trial, which is a multinational prospective randomized open-label study that is comparing edoxaban to VKA-based therapy in approximately 1,400 patients with an indication for chronic oral anticoagulation after a successful transfemoral TAVR. A single antiplatelet therapy in association with either edoxaban or VKA will be possible at the discretion of the local physician with a dedicated stratification on these particular parameters. And the co-primary endpoint with, as previously described, include the major bleeding endpoints and net adverse clinical events, which will be the composite of the ischemic and bleeding events. This study is powered to detect non-inferiority for the composite primary endpoint, followed, if positive, by a superiority testing. So overall, what can we say about antithrombotic therapy in TAVR? What we know is that severe bleeding occurs in approximately 10% of the patients following TAVR. And we know that severe bleeding is more frequent when you use dual antiplatelet therapy than single antiplatelet therapy. And it's also most frequent if you use antiplatelet therapy on top of oral anticoagulation. We know that the most dreaded ischemic complication, that is stroke, occurs in up to 5% of the patient within 1 year. And we have no reason to believe yet that dual antiplatelet therapy would do better than single antiplatelet therapy to prevent stroke. We have neither any strong reason to believe that the addition of antiplatelet therapy to oral anticoagulation therapy will also prevent from the stroke. Concerning subclinical leaflet thrombosis, we have seen that hypoattenuated leaflet thickening occurs in approximately 40% of the patient, while a reduced leaflet motion may be found in up to 6% of the patient. And we have reason to believe that oral anticoagulation may treat or prevent from this thrombotic event. However, we have no reason to believe that dual antiplatelet therapy is actually doing better than single antiplatelet therapy for this specific complication. And finally, we have seen that acute coronary syndrome is a relatively uncommon complication despite the high prevalence of coronary artery disease at baseline. And we have received so far no signal that dual antiplatelet therapy or oral anticoagulation, for that matter, significantly protect from this complication following TAVR. So how should you treat your patient undergoing a TAVR? Well, for periprocedural anticoagulation, you should use an ACT-guided and fractionated heparin and follow the procedures if your patient did not present with a recent acute coronary syndrome or a coronary stenting, and if he does not present with an indication for chronic oral anticoagulation, then you should probably use a single antitherapy in this setting and an oral anticoagulation if he has an indication for it aside from the TAVR. And for that, you could use vitamin K antagonist, but you could also consider a NOAC. Now, if there is a recent acute coronary syndrome, or if the patient were recently treated with a coronary stenting, then you should consider a 3 to 6 months period for dual antiplatelet therapy that would be then switched to single antiplatelet therapy. And in case of indication for chronic OAC, then you should consider a double antithrombotic therapy for a short period that would be followed by oral anticoagulation only. Overall, the bioprosthetic valve has a prothrombotic environment. Atrial fibrillation and new onset of atrial fibrillation are strong determinants of cardiovascular events. And antithrombotic regimens are so far based on expert consensus and influenced by patient comorbidities. And it is quite challenging to determine the optimal antithrombotic treatment in this population, specifically with the low-risk population. Thank you very much.
Well, this has been a great and extensive talk. I asked the organizers if we have time for some questions. Yes, we do. 5 minutes? Okay. I will very briefly raise one point. At the very beginning, you started with the need for measuring ACT intraprocedural. That was a paper published 5 or 6 years ago, and at that time, a TAVI procedure took more than an hour and a half. Now, we give heparin at the time we implant the prostart, and this is about 8 minutes before putting the valve. So the time you give heparin and you check the ACT, you give protamine, because the TAVI procedure is finished. So unless you have complications and the procedure go longer than 45 minutes, we don't check anymore. I mean, it's quicker to do the TAVI than checking the ACT. So I think we don't use this anymore unless the procedure goes much longer. Yeah.
Do you think, until we have more evidence, that the antiplatelet therapy in patients without indication for anticoagulation should be different in patients with annular disposition of the valves in comparison with the devices, with supraannular devices? Because, for example, double antiplatelet therapy for annular valves, but single antiplatelet therapy for supraannular valves, Does it make sense, or?
I don't think so far that we have strong reason to believe that dual or single antiplatelet therapy actually impacts the occurrence of subclinical leaflet thrombosis. So I don't think, with respect to the use of antiplatelet therapy, that it actually matters. And with respect to the use of systematic oral anticoagulation in this patient, well, that would be a viable question. But as we have seen in the Galileo trial, maybe you reduce the rates of subclinical leaflet thrombosis, but it doesn't matter if you increase the risk of bleeding and the overall death. So I think that so far it's not, maybe we should not adapt the treatment solely on this criteria.
We have observed a disconnect in Galileo between the valve effect of rivaroxaban and the clinical outcome. And I very much liked your synthesis of potential way how to treat patients without indication for oral anticoagulation, basically indicating single antiplatelet therapy. But my question to you is, if you look at surgical practice, what they widely do is they anticoagulate for a period of 3 to 6 months prior to switching to antiplatelet therapy. What do you think about that approach?
Obviously, there are differences with the performance of the surgical aortic valves and the transcatheter heart valves. And you can see that in the rates of subclinical leaflet thrombosis, which is more frequent in the transcatheter valve than it is in the surgical aortic valve. So maybe there would be a reason for a systematic oral anticoagulation in the transcatheter aortic valve, which seems to maybe perform slightly less better with respect to the occurrence of thrombosis. But again, you have to wait it with the clinical event.
And perhaps another question, I'm rather intrigued by the France 2 data where you have a relevant increase in mortality related to anticoagulation. And I think the question that arises is a little bit whether the therapeutic efficacy of anticoagulation in the very elderly population, that is octogenarians or older, is the same as in younger patients. So in other words, are we so certain that we do not do harm with systematic oral anticoagulation in the very elderly, even if there are indications in terms of atrial fibrillation?
Yeah, that was a signal that was risen by the particular studies, that the increased risk of oral anticoagulation, particularly in this very frail population.
Because if that would be a concern, then we should investigate other things like LAA closure as an alternative, at least in the very elderly patient population.
Although you can then have a problem of thrombosis of the device itself, which, you know.
Just a comment about the comparison between surgical patients and TAVI patients. I think the data we have in surgical patients are not applicable to TAVI patients because we are treating patients that are maybe 10, 15 years older with a very higher risk of bleedings. No? Maybe this is one of the reasons why the Galileo results were not consistent with some data from surgical patients.
Most likely, and also in the Galileo trial, there was the association of oral anticoagulation, even at a lower dosage, and systemic antiplatelet therapy that was associated with it, increasing the risk of bleeding. So we will see with the Atlantis trial if a single antithrombotic therapy with oral anticoagulation would be safer.
Well, thank you very much for your presentation. It was very, very nice. There is 2 points I want to make. There is data now coming out saying that platelets in patients with valve diseases are not effective because the shear stress of the valve is producing renovation of platelets very often, and these platelets are not very active. Therefore, blocking platelets to avoid thrombosis in the valves is not the strategy. Maybe for the comorbidities, but not for the valves. And also we have the problem that the valves being treated with anti-10A is not the best mechanism because these are mechanical valves and they have to be, the contact activation of coagulation should be blocked. So what we are having is bleeding because anti-10A is not the best target. We don't have targets for anti-12, but they are being developed now. So meaning that we are anticoagulating, but not with the indication that is the needed one, that is blocking factor 12. We don't have it, we will have it in the future. In the meantime, factor 11, factor 10 inhibition is being used, but it's not indicated. That's why we have problems because we are not targeting what we want. And vitamin K anticoagulation is better because it's a general blockade of the coagulation system. So in some instances, we are pushing for anti-10A, but this is not the best for blocking contact activation of coagulation. So in the interim, obviously, we are trying with all the trials, but we have to concentrate that the valves produce a fibrin thrombus, not a platelet-rich thrombus.
I think this is a very relevant point. And actually, the observational data that I showed you with the use of NOAC was, oddly enough, showing that NOAC may not be that safe in this particular setting. So we'll need confirmation from ongoing control randomized trial, but this is a very legitimate and relevant question that you're raising.
So I think that this new type of drugs with a targeting factor 12 are very much needed, because every time we have more patients treated with valve replacements, and I think it's an important target. Thank you.
Okay, I'm sure that we might have many more questions to make, but we're running a little bit late, so thank you very much. And we call the next chairman, Dr. Aradi and Dr. Alfonso. Thank you.